Thank you, Equin. Well, good afternoon, everyone. This is a joint committee session of our Public Safety Committee as well as our Health and Human Services Committee. I'm joined by the members of the committee and my co-chair, Councilmember Sidney Katz, and we will be tag teaming this afternoon's session, which is a very important one. We have been talking a lot, understandably, about reimagining the way that we carry out first response and the way that we carry out law enforcement. And one of the areas where there has been tremendous agreement is needing to improve upon and expand the services that we provide, both on the front end in addressing sometimes what can be life or death situations involving residents that are in crisis and in need, and on the back end, making sure that there are proper referrals and that we are in a position to be able to holistically help both the resident who he or herself is suffering from mental health challenges, but also their families, and ensuring that we have as tight a system as possible. And so we will be covering 3 items, all connected in some form or fashion this afternoon before the joint committees. And the first item will be a review of a very well done OLO report that will Ms. Carrizosa will be walking us through. The second will also be a briefing. The first is a briefing. The second is a briefing on where we are with our mobile crisis team and crisis center. And the third will be a work session to discuss the supplemental appropriation in the FY21 operating budget to the Department of Health and Human Services for a little over $500,000 for medication-assisted treatment programs. And so we will be voting on that later this afternoon. But with that, I want to acknowledge this great team from our executive branch that is here today. We are joined by representatives from MCPD, and specifically Chief Jones and Assistant Chief Dinesh Patel. We also have Dr. Raymond Kroll here, the director of our Department of Health and Human Services, and he has a number of folks with him on his team. And we, of course, are joined by, in this first part, Ms. Natalia Carrizosa, who is the author of this OLO report and will be walking us through it as well. Before I get started, Ms. McMillan, was there anything that you wanted to add in setting up the context for the discussion that we're going to have this afternoon?
No, I think I'll turn this first item over to OLO and to Ms. Carrizosa, and then we'll take it from there afterwards.
Great. And Chairman Katz, was there anything you wanted to add at the outset?
No, Mr. Vice President, it was all said very well, and look forward. And you're right, all 3 of these topics are intertwined. So it's very wise to have the 3 topics at the same time. Thanks.
Great. Ms. Carrizosa, the floor is yours.
Thank you very much. Good afternoon. I'm here to present the findings of OLO Report 2021-4 on public safety responses to mental health situations. I'm going to take about 15 minutes to make a PowerPoint presentation, so I'm going to go ahead and share my screen here. But before I get started, I do want to take a moment to thank everyone who took the time to share their insights and provide information and data for this report. We, as always, received a high level of cooperation from everyone involved, so we really appreciate that. So I'm going to go on to the next slide here. We conducted this study to respond to the Council's request to examine the county's capacity to respond to mental health situations. I'm going to begin the presentation by summarizing the research on policing and mental health situations. Then I'll talk about the county's resources and training for mental health responses. I'll then describe data on public safety responses to mental health situations. And finally, I'll go over OLO's recommendations and discussion issues. So the next 3 slides are going to be about the research on policing and mental health situations. The research shows that mental health situations present numerous challenges for police and too often result in poor or tragic outcomes for persons with mental illness. Some of the challenges include the time and resources spent by police training for and responding to mental health situations, which take longer than other types of responses, a lack of hospital capacity for receiving and treating individuals with mental illness, the criminalization of mental illness, the potential for escalation and uses of force during police encounters. And the slide also mentions racial disparities. There isn't comprehensive national data on the demographics of individuals involved in these responses, but research does show that while Black, Latinx, and Asian individuals are less likely than white individuals to use mental health services, Black individuals use psychiatric emergency services and are subject to involuntary hospitalization at higher rates than white individuals. The Substance Abuse and Mental Health Services Administration released guidance last year that calls for communities to develop behavioral health crisis care systems that reside outside of the criminal justice system and minimize law enforcement involvement in crisis response. This guidance is based on the Crisis Now model, and that includes the 3 components listed on the slide: a crisis call center, mobile crisis team services, and crisis receiving and stabilization services. One of the key elements highlighted in the federal guidance is collaboration between crisis care systems and law enforcement. The Vera Institute for Justice produced a summary of the research on a variety of models and tools for crisis response and police mental health collaborations. And this slide just summarizes 3 key models or tools. The first is the Crisis Intervention Team Model, or CIT, which is a police-based model that's primarily known for its voluntary 40-hour training program for law enforcement personnel. CIT training is delivered jointly by law enforcement, mental health providers, and advocates, and its goal is to train law enforcement personnel to respond effectively to mental health situations, to improve officer and consumer safety, and divert individuals with mental illness from the criminal justice system. The second tool listed on this slide is co-responder teams, which is when police are paired with mental health professionals. And the third is mobile crisis teams, which are mental health teams that provide interventions in the community, sometimes in collaboration with police. Research does show that these tools have the potential to have a variety of positive outcomes that include reduced arrests and uses of force, reduced emergency department visits, and increased use of community-based mental health services. But the research is somewhat limited, and there are some methodological challenges. And in addition, the outcomes often depend on the availability of mental health services in the community. So to better understand how these tools worked, we looked at 6 case studies that are listed on the slide. These are jurisdictions that have developed strategies to improve crisis response. And we identified the following trends. The first is that most jurisdictions use more than one approach for mental health response. So it's not either CIT or co-responder teams or mobile crisis. Several of these jurisdictions use all of these models. Some jurisdictions divert certain responses to mental health situations away from police. These are typically mental health situations that don't involve crimes or dangerous elements. Another trend we saw is that specialized mental health response teams, which could be either the co-responder teams or the mobile crisis teams, in these jurisdictions, they tend to have longer response times than police, so they often respond to less urgent situations or provide a secondary response after the initial response by police. The fourth trend that we saw is that engagement and training of emergency dispatchers is a key element in several jurisdictions, including jurisdictions that use different approaches. And then the last trend is that trust and relationship building between mobile crisis teams and police departments is really critical. And this is particularly important or highlighted in the case studies that were working to divert certain responses away from police. So during the next 5 slides, I'm going to go ahead and talk about resources and training for mental health responses in Montgomery County. We have this slide and the next slide summarizes the non-public safety resources. The Montgomery County Crisis Center provides crisis services.
County, deserve an aspect, the residents of Montgomery County. The residents of Montgomery County.
The Montgomery County Crisis Center, as I was saying, provides crisis services by phone and in person 24/7, and they get about 100 calls and 15 walk-ins per day. They also have 4 crisis beds that provide an alternative to hospitalization for persons in crisis. One of the key concerns that we heard from staff is that although the crisis center does provide an alternative to hospitalization, its capacity is not sufficient to meet the needs. And this limits how effectively the county can serve individuals experiencing mental health situations. Then on the slide, we have the mobile crisis outreach team, which responds in the community. Currently, they respond with police, although they are working on developing protocols to respond without police. And they respond to an average of 40 incidents per month. Last year, there was a state grant proposal. The county engaged with RI International to analyze the capacity of the mobile crisis outreach team, and that analysis found that an estimated 8,140 individuals would meet criteria for mobile crisis outreach team services annually. So that would represent about 700 individuals per month. And as you know, last year, the council approved 6 new positions for the mobile crisis outreach team. These data don't reflect that increased capacity because the positions hadn't been filled for the time period reflected in the data. And then the last item on this slide is the Montgomery County hotline that's operated by EveryMind, which provides supportive listening, information, and resources, as well as crisis intervention, and they get about 44 calls and 9 text or chats per day. And then 2 more resources that I wanted to mention. MC311 is the county's non-emergency call center and web portal, and they get an average of 3 calls per day regarding mental health or substance use issues. And then Maryland 211 is a nonprofit organization that provides information and resources on health, crisis, and social services, and they have 4 call centers across the state. Montgomery County residents are directed to the call center in Prince George's County. Overall, Montgomery County accounts for about 6% of 211's call volume. 211 provided OLO with some detailed data on calls to 211 from Montgomery County, and the data showed that 211 gets about 25 mental health or substance use related calls per day from Montgomery County. And we did hear feedback that there are opportunities for collaboration between the county and Maryland 211. This slide summarizes the public safety resources for mental health situation responses. The Emergency Communications Center is responsible for answering 911 calls and non-emergency police calls and for dispatching public safety personnel to incidents that include mental health situations. Police patrol services, including Montgomery County Police Department Patrol Services Bureau, as well as municipal and other law enforcement agencies in the county, are often the first on the scene for mental health situations. MCPD's Crisis Intervention Team program is staffed by 2 officers and 1 DHHS clinician, and they coordinate CIT training for law enforcement personnel in the county, and they respond to complicated mental health situations. Montgomery County Fire and Rescue Services often responds alongside police and sometimes responds alone to certain mental health situations. And the Montgomery County Sheriff's Office, specifically their domestic violence section, is responsible for serving petitions for emergency evaluations that are filed by health professionals or private individuals. A petition for emergency evaluation is the first step for evaluating a person for involuntary hospitalization. So as the previous slide showed, several public safety entities are involved in responding to mental health situations, and these next 2 slides summarize the training that each group receives on this topic. Emergency Communications Center staff do receive some training on handling stressful situations, including suicidal callers, during their entry-level and annual in-service training. However, they have not recently been able to participate in the 40-hour CIT training due to staffing constraints. This was something that they did frequently participate in the past. With regards to MCPD police officers, at the time of writing, 58% of them had completed the 40-hour CIT training program, and all officers had completed either CIT or an 8-hour mental health first aid course. Recently, MCPD made CIT training mandatory for all police recruits, so police recruit training now includes both mental health first aid and CIT. Oops. And then this slide has the training, summarizes training for Montgomery County Fire and Rescue Services and Montgomery County Sheriff's Office deputies. Fire and Rescue Services staff reported to us that EMTs and paramedics do receive some minimal training on mental health and substance use issues. It adds up to about 2 to 3 hours during their initial training, and then paramedics receive some additional training during their rotations. Those 2 to 3 hours do not include training on responding to medical issues like overdoses. This specifically relates to the behavioral health aspects. And the other part of this slide is the Sheriff's Office. Deputies receive training on mental health situation responses during their entry-level and in-service training. All deputies assigned to the domestic violence section, which serves petitions for emergency evaluations, must complete the 40-hour CIT training. So the next slides are going to go into the data on public safety responses to mental health situations. Data from the emergency communications, this slide has data from the Emergency Communications Center from September 2017 to May 2020, as well as and some additional data from Montgomery County Fire and Rescue Services patient care reports from January 2018 to October 2020. And it lists some of the key data points that we found from these sources. On the police side, it shows that there were, during the period that we looked at, there were an average of 19 responses to mental health situations per day. As a caveat, these data do not include every incident involving a person with mental illness. For example, incidents involving a major crime would likely be categorized under that crime rather than as a mental health situation in this particular data set. What the data show is that in addition to officers responding to mental health situations numerous times per day, these responses also take longer than other 911 calls. Mental health situation responses take an average of 154 minutes of police time on average, including the time spent by each unit from dispatch to clearance. This is over twice as long as other 911 call responses. About a third of police responses results in a petition for emergency evaluation. So if an officer determines that an individual with mental illness presents a danger to themselves or others, they must transport the individual to a hospital emergency department for evaluation. And then finally, use of force report data from 2019 show that 30% of MCPD uses of force in 2019 involved suspected mental illness, and this indicates that mental illness is a risk factor for uses of force by police. On the Montgomery County Fire and Rescue Services side, we found that for 28% of those police responses to mental health situations, fire and rescue provided a dual response. And separately, patient care report data show that fire and rescue services treated about an average of 10 patients per day with mental health concerns. Finally, data from the Emergency Communications Center don't include information on the demographics of individuals experiencing mental health situations, but we did receive demographic data from other sources for 2 cases. The first is individuals served by the DHHS Mobile Crisis Outreach Team. And the second is individuals for which police filed a petition for emergency evaluation. This slide summarizes race and ethnicity for these groups, and the data show that Black individuals are strongly overrepresented and Latinx and Asian individuals are underrepresented in these groups compared with their population percentages. So I'm going to go ahead and close with OLO's recommendations and discussion issues. This slide shows our 2 recommendations. The first is that the executive discuss with Maryland 211 opportunities for collaboration for responding to mental health and substance use crisis calls. The second is to request that MCPD report key data points on responses to mental health situations and associated uses of force. The data points shown on the slide are based on federal guidance for CIT programs. And then this slide offers two discussion issues for the Joint Committee. The first is regarding public safety resources, training, and procedures for mental health responses. As I noted, MCPD recently made CIT training mandatory for police recruits. They're also working to enhance the crisis intervention team program and updating their policies. The Joint Committee may wish to discuss these changes as well as options for enhancing training for Emergency Communications Center and Montgomery County Fire and Rescue Services personnel for responding to mental health situations. The second discussion issue relates to the county's ongoing efforts to reduce reliance on law enforcement for mental health situations, and that's going to be addressed in the second item on the committee's agenda today. So this concludes my presentation. I'm now going to turn it back over to the committee and stop sharing my screen. Oof. There we go.
Wow, that was very powerful. I think, so many headlines, but just last year alone, almost 7,000 cases that required response is remarkable when you consider the sheer volume, and the 154 minutes also very relevant and important in terms of context. I had a few specific questions with regards to the report. I know Chairman Katz has questions he'd like to ask as well, and I would like to give Dr. Kroll and Chief Jones the opportunity to provide some of their initial feedback and thoughts on the report itself and anything that they feel is helpful to this discussion. But how do we define mental health issues? Because that's obviously a wide range. And you've got very acute issues, bipolar, paranoid schizophrenia, depression, people, and do we disaggregate? Is the data disaggregated to identify, for example, when somebody is high on a drug and is exhibiting unusual behavior, whether it's PCP or cocaine or some other drug, and being able to differentiate between whether someone's high versus whether they have, a mental health issue or going through a challenge. And of course, that doesn't include behavioral health issues, such as folks that are high in the autism scale, et cetera. How is mental health defined, or is it defined?
That's a great question. The data that we looked at is based on the disposition code that is assigned by the officer, and it is not disaggregated by a specific, diagnosis or a specific behavior that is observed. So we as OLO are not able to kind of assess whether that determination was correct. It's certainly the case that we've heard anecdotally, and as well as in the national research, that sometimes other types of issues, for example, intellectual and developmental disabilities can be confused with mental health situations. It's certainly possible that that could be occurring in the data that we're seeing here, but it's not disaggregated.
I appreciate that. And then I'm very familiar with the CIT training, and it is a best practice that we require it of all newly sworn officers. And it is, an intense 40-hour training that doesn't just end. It's contiguous. There are updates to that training on a, and I'll have to defer to the chiefs to find out exactly how often those updates to that training, those trainings occur. But I think it is important. And I've shared this publicly several times, but last year, I remember shortly after the George Floyd incident, and of course, there have been too many to count, both before, during, and after since that incident. But I remember Dr. Kroll and Chief Jones being together. This was back when we could actually meet in person. And I remember vividly just how powerful that image was of the director of HHS standing next to our police chief, discussing how intertwined and interconnected all of this is. And so as we discuss the implementation in the second item on the agenda, I think we have a strong foundation here, and we're fortunate, frankly, to have Dr. Kroll, who happens to have a behavioral health professional background, heading up HHS. So he's uniquely positioned to help address these issues. So I'll defer to you, Mr. Chairman, to see if you have questions specifically of the report, and then I will ask Chief Jones and Dr. Kroll to make some comments, and then turn it over to my colleagues for additional questions regarding the report as well. Chairman Katz.
Thank you very much, Mr. Vice President. And once again, OLO, you've always do an outstanding job, and this one was an outstanding job. You did unbelievably great information, and information that we need to discuss and that we will continue to discuss. My first concern, though, is about the whole idea of 211. Persons having a crisis, do they even know about 211? Do they even think about 211? How do they know of 211? And if you're having a crisis, how often do they just say, you know, the only numbers I remember is 911? How do we have any statistics on that?
So I'm not aware of any kind of survey data that would show what folks are aware of. And I'm not sure exactly how 211 is being publicized in the county and how folks are learning about it. All that we know from the data is that it is being used on a regular basis by county residents. And it's a resource that folks are taking advantage of.
Council President Hucker, I think, has a point.
Yeah, no, he's been jumping up and down with this.
Chairman will allow me. I had the same question, but sort of the reverse. I was going to ask Natalia, did I write this down right? That and I hope you'll share the slides. But
Sure.
311 gets 3 calls a day from Montgomery County residents, our program, but the state's 211 program generates 25 calls per day from Montgomery residents, not statewide residents?
Correct. And those numbers are referring specifically to the calls that are related to mental health and substance use issues.
Right, but thank you.
Yeah.
But so in the same constituency, so same cohort of residents, mental health and substance abuse.
Correct.
So what is the state doing that's somehow 8 times more effective per day at generating calls from this needy population than what we're doing? That's
Well, the other question has to be,
I didn't
but the
think
other
so many
question,
people were aware of 211 either.
but the other question has to be, how many of those are unique callers? Is it a caller that's calling back several times in a day? I mean, you know, that's my concern.
Right, but I had the same as you, Sydney. That I didn't think too many people knew about 211, and apparently a lot of people do, or a lot of these folks do, because 8 times more are calling than calling 311. Sorry.
Yeah, no, I think, and I guess we don't know the answer at this point, is what we're being told. But I do think it would be something that would be helpful to tell us as well. So the other points that I wanted to make is, first off,
Mr. Katz, Dr. Kroll, I think, wants to answer that. He may have an answer for you.
Please.
Sorry, I just want to thank you, Councilmember Rice, and thank you all for the session this afternoon. Just a quick note on 211. 311 is our universal call system for everything unimaginable, from roadkill to crisis response to anything short of 911 is a 311 informational call. 211 was stood up by the state probably 8-9 years ago, maybe, as a human services call service, and so it has gotten some reputation amongst provider networks and amongst folks who moved across counties and through counties. And although the county made a decision not to align with 211 at the time they were standing up 311, the 211 has still gained some traction in the human service area. So that may account for the increased number of calls that you're seeing there, as opposed to getting to 311. It's a more specific and tailored service.
If someone calls 311 in Montgomery County, do we advise them that they should call 211?
I don't know that that's the case. I don't know. Usually, if they're calling 311 for a human service, they should be put through to whatever the service is they're requesting in the county as a first choice.
Okay.
It might, however, one of the things about 211 that is unique is that it is not only a government service connector, it is also a provider connector. So there are provider connectors connections that might make it useful for 311 to refer to 211 for additional resources.
I do have some additional information here that may impartially answer both very reasonable questions. So For families that have somebody in their family that has mental health issues, the provider community does promote the 211 number within those families to call prior to calling 911. And so I have some personal experience with this in my own family. And so it is a number that, it's for families that are experiencing this and have family members that have mental health challenges. They're aware of a lot of the resources that are available to them. And 211 is one of those resources. They're often not cold calling.
Okay. And then, do we know how often when a mental health professional is called to the scene, do we know how often that the mental health professional requests a police presence with them?
So currently the team that is mental health professionals that goes out to these situations is the mobile crisis outreach team, and their current policy at the time of writing was to respond with police in every case. So right now for the mobile crisis outreach team, it would be 100%, but I don't know. I don't have data from other providers as to whether, mental health providers that were otherwise responding would have requested police.
To me, that's something that I like. I mean, and maybe it's just a survey. I don't know. But to me, that would be something that would be helpful to know. Because obviously, and then the other question, since we're going to survey, since we're going to ask, is once they go out with the police officer, then how often do they feel that they need that police officer for the second or third time that they meet with the same person, or however whatever their follow-up is with them? If a person, and I guess this is of the chief, but if a person is threatening the horrible situation of a suicide situation, is that person arrested? How does that work? I know that it's an emergency petition, but if the person says, I'm not going, what happens in that situation?
Well, thank you, Councilman Katz. So under the Maryland state law, a person who's threatened to do harm to themselves or to do others, it gives us the authority to take that person into custody in order to take them to a medical facility for evaluation. So there is no necessarily, unless they've done a criminal act, but if there's no criminal act done and they're just threatening suicide, we can take them involuntarily to that medical facility, i.e. a hospital, to be evaluated by a physician. And we are required by law to submit a sworn statement of facts of why this person was taken into custody as a result of the actions that they exhibited, statements made to basically that would have caused us to put that person into custody to bring them to the facility.
Thank you. And so it's not an arrest situation.
No, it's not an arrest, but they could be physically restrained, right? Based upon the condition of that particular individual, we could place the individual in restraints in order to take them to the hospital.
And for a substance abuse call, and I know we've had these discussions before, and I think I'm right on this, and if I'm not, please correct me. But if someone calls and says there's an overdose, there is not an arrest associated with that overdose, correct?
That's correct. There's no arrest made in an event of an overdose, correct.
And Natalia, on the 154 minutes of police time, that I would assume is saying that if 3 police officers respond to that call, that it's not like that it's 2.5 hours that call takes. It's police time of the 3 officers divided by 154. Is that
Correct.
is that correct?
That's correct.
And the other thing that, and I'm going to stop because I know others have questions too. But the other thing, on your second bullet on page 1, in the packet, you say that we review the county's non-public safety and public safety resources and processes for mental health crisis responses. I understand that we're talking about different resources in a police resource or fire and rescue resource. But candidly, I really believe that when we're talking about the mental health resource, and it's also a public safety resource as well. I mean, if a mental health professional, if someone is in crisis and they call 211, 311, whoever they're calling, whatever the 11s they're calling, it's a crisis for public safety. And so, and I understand it's semantics in some cases, but I do believe that should also be considered, though we're certainly reconfiguring it. I also believe that's considered something that we are taking as quickly as we can, and it's a public safety response. So anyhow, thank you, Mr. Chairman. I'll turn it back.
Thanks, Mr. Chairman. Councilmember Rice has his hand up. Before we go to Councilmember Rice, I wanted to give Dr. Kroll and Chief Jones an opportunity to just provide your initial thoughts from 30,000 feet or in the weeds or whatever you'd prefer with regards to this report, and then we'll get back in the queue for the specific questions. Dr. Kroll, if you want to go first.
Sure, Council Chair Albernos, Committee Chair Albernos. Good to see you again. Since yesterday or the day before.
Yeah.
So first of all, I think
20 minutes ago. Yeah.
First of all, let me say that once again, OLO has done its usual outstanding job in delving into an issue and coming up with a good set of conclusions and some recommendations for us to follow and to respond to. I think of course, I won't go into all the history and review the report. It's already been done, I think, quite well. There are probably some questions I would ask, but we can do those in terms of data and in terms of understanding some of the disparity issues that Natalia talked about. But I would say this: all of the things the models that were identified in the OLO report are present and have been present in elements of Montgomery County's public safety response to your point, Councilmember Katz, around mental health and substance abuse. CIT, call responder teams, case management services, and of course, mobile crisis. And we've grown a cadre of peer recovery specialists, and the state has a statewide training that we use to train peer recovery specialists to bring more of those folks online as we go forward. The collaboration has always been, in the time that I have been here, has always been good between law enforcement and mental health in the county. The challenge is, of course, behavioral health over the years has struggled in terms of its size and scope and capacity to respond. At one point, we had 2 mobile crisis response teams that were running continuously, and we had a group called the Public Inebriate team that was out on the streets doing work. We had a much larger crisis center staffing than we do now. Over the years, that has eroded until we ended up with just the 1 mobile crisis team. Last year, thanks to Councilmember Hucker, we got a jump start on what you'll hear about a little later in terms of mobile crisis and outreach teams. And there is, I'm happy to say, in the county executive's budget, which you have in front of you now, is a proposed expansion beyond that you'll hear a little bit about when we talk about mobile crisis outreach. Your comment, Councilmember Katz, about mobile crisis outreach responses with police, and I think, yes, the history has been that crisis center teams responded with police historically, and that is something that we're looking to change as we implement the Crisis Now model. And the other piece is that is online since we started talking about this last year. There are changes in 311 and its operating system. So we are working to stand up a central call center in HHS that will field calls from the public and from 311. We'll take those calls from 311 as a way of helping people to navigate their way around in the department. The part of that work will be to engage with 211 and to try to make sure that we are linking with them in a very real way. So that is something we'll talk about, I guess, during the course of the day and over the next week or so. And then the last one for me is just a comment. Yes, we've always thought of behavioral health and mental health responses as public safety responses, as much for the individual as it is for the community. Mentally ill folks kind of can be at greater risk sometimes for injury and for assault than the general public is. So we want to make sure that we can get out and get to people when they need to get out there. And the last thing I'll say, because I know that Councilmember Glass is listening, is that when we think about mental health and outreach, mobile crisis and outreach process, that includes for us outreach and engagement with the homeless community. So what you'll hear today is mostly about the mobile crisis outreach team, but when you hear outreach team, I want the community to begin to think of our outreach work that we do with the homeless community as a part of that system as well. So it's a broader response array than just someone in the crisis center responding to a call that comes in through 911 or 311 or any other source. So I'll stop there for a minute, turn over to my colleague.
Keith Jones.
All right, thank you, sir, and thank you to all the committee members and Councilmember Albanaz and Councilmember Katz for leading this. There are several issues to be pointed out. I think when we talk about the training, we've done, and I know when OLO, and again, I want to commend them on, I believe, and I concur with Dr. Kroll, an excellent report that I think really highlights a lot of the issues that are currently in Montgomery County. As we talk about some of the issues, the first thing I would talk about is in regards to the training that I think we've made a true commitment to mental health training amongst our officers. And at the time, I know in this report it says that 57% of our officers are trained in CIT. Now we are even up to close to 67% of our officers who are actually being trained. I think 58% probably in the report. And that just again shows the commitment and really working with our recruits, knowing that they're getting this when they first get on the department, when they're getting the basics, and then we're giving them, and 100% of our department has mental health first aid training that I think again is important. And to answer your question, Councilmember Albanaz, is the fact that our officers, even though they're CIT trained, or even have mental health first aid, that we also provide additional training in service training annually, generally 1 to 2 hour blocks of additional updates about mental health things that we have learned and that we need to share with our officers to give them the more tools to be successful. I know we talk a lot that sometimes these incidents end bad. I know we don't really talk a lot about the good results that we have in many of these interactions that our folks get involved with on a daily basis. These, again, the calls for service, as noted, something that we really need to talk about, because what's kind of difficult to really kind of put this in a category, and I think there are some ways for us to get there, but it's going to take a little bit of an investment because we clearly have what we call clearance codes that says at the end of this incident, what's the clearance of the call? Because every call that comes in, although we think we know what we're going to, we sometimes get to a call and it's something totally different. And it may be, for example, you may be thinking that you're just going to a simple assault call, but it does involve a case of an individual that's having a mental health crisis. And so that call would have been classified as an assault. And there's no checkbox that says that this has possible mental health or this is a mental health situation the report might have some information in there that relates that. And generally our reports are written, and that's in a narrative that helps. For example, if it is an individual who's charged with a crime, that it helps the state's attorney's office, as an example, as the prosecutor will be reviewing the case, and maybe it's a case that goes to the mental health court, because they can tell based upon the narrative that this had some degree of mental health background to it. But there's a wide variety of different calls. For example, the most recent incident involving the Montgomery County Deputy Sheriff, that we had, that call came in via basically a vehicle crash. And that's how we got there, and then things turned differently. So that makes it a little bit more challenging. And even with call takers, I have a lot of confidence, and I agree that we need to do more training, but to have our call takers, who may not know and may not be qualified to ascertain or to know for a matter of fact that this is a mental health call, unless the caller has specific information that supports that. And so there are a wide variety of sort of how we get to the end result. I mean, even when we take individuals to the hospital, we don't wait to hear what the final, determination by the doctor of whether this individual had a mental health crisis or not. We take them to doctor, and once the hospital takes custody of the individuals, then we leave. And we don't literally stay around to see what the end result and what is the actual prognosis of the actual individual, because again, it's a health issue, that we're not privy to. But I do want to just talk briefly. And again, I think the crisis now model is really where we should be going. Dr. Kroll and I've been an advocate for this from the very day that I first heard it. And I think it is a win-win about where this county needs to get in the long run. But I do want to briefly just highlight talking about our amount of time that our officers spend on these calls. And Councilmember Katz was absolutely correct when he was noting that it's the aggregate. And then some of these calls, we're sending more than just 2 officers, right? We might have to send 3, 4, 5 officers, depending upon what the situation is. But again, when you look at the longevity of it, let's say an individual who does have to have an emergency evaluation petition completed upon that, it does require that officer, whoever is the lead officer who takes that person into the custody and to take them to the hospital. We have, however long we dealt with them. Well, one of the reasons we look at how long we deal with people is because of the de-escalation training that we're teaching now. It's really focusing on slowing things down. And when we slow things down, we're really slowing them down to sometimes a crawl in order to make sure that we can handle this and get that person where they need to be and not have to utilize force in many of those cases. And so that adds more time into this equation, but also for the fact that, where we're trying to go, where we're being able to get those people to a place, drop them off, and we're done. There are times where we have to take individuals to the hospital, and we literally have to sit there with them until the hospital is prepared to take custody of them and then and take the evaluation and for them to be seen. And so I think, we've had that discussion with our hospitals, particularly our emergency rooms. We're going in, we're spending an amount of time waiting for them to be able to, depend upon which hospital it is and how busy they are at the facility, how does that flow in the timeline in which we deal with. So with all that being said, I'll stop there, but I think that just to give you a little bit of insight on how some of the complexities of us handling mental health calls. And again, I think Natalia did a really good job of really on her research to really highlight the different agencies and how, even though in some cases we're collaborative, of course, with, for example, HHS and a mobile crisis team, which again, I think we still have to realize there's going to be a need for that. That's not going to go away. It doesn't have to be 100% of the time. I probably would agree, but there's still going to be the time that mobile crisis will say to us, can you please escort us, as we do with fire rescue in some cases, to make sure that the scene is safe before our first responders. And in this regard, I would even deem our mobile crisis team first responders as they are trying to deal with these situations in a public safety manner. So I'll pause there.
Thank you, Chief. Super helpful. Councilmember Rice, followed by Councilmember Glass, and then Councilmember Hawker.
Thank you very much, Mr. Chair and Mr. Vice President. Let me just jump into one of the specifics, and I'm not sure who may be best to answer this, but we know that oftentimes, unfortunately, in our community, those who are autistic, as well as those who have developmental disabilities, are oftentimes mistaken as those who are experiencing mental health challenges. And so what is going into the training to discern the difference between the two? And what are the differences in terms of response mechanisms that we're looking to be as a part of this plan? And I know that as we're looking to still make sure that the plan involves everything, there may not be an answer today, but and if not, that's perfectly fine. But if there are some initial thoughts and as to how we're making sure that folks are able to understand and ascertain the differences and also be responsive and receptive to what those different needs may be as they respond to a situation.
So, Councilmember Rice, I appreciate that. I will say, I think Montgomery County, and I will say I am very proud of, we have one of the leading experts in autistic police response, autism response, and Officer Lori Reyes. Lori has wrapped her arms around this program. She has trained the entire police department and beyond. And as you all know that or have known, Lori has done a phenomenal job of coordinating with the autistic community in Montgomery County to invite them to events that we've sponsored on Autism Night that brings them together with our police department to help, be able to bridge the gap, you might say, right? To help, and our officers are really well trained in the sense of identifying individuals who suffer from autism, and to be able to utilize again de-escalation techniques and things of that nature. Particularly we have cases where individuals are lost, autistic children are lost, are run away from home, and we have key factors that we focus on, and our search teams are well versed in sort of knowing where these individuals tend to go, and we really have really good success stories as it relates to that. So we always want to be able to expand upon that type of training, because I don't think you get trained enough, right, in making sure that we get that right. And I think that's an important factor. But I will say I am, when I get a lot of calls from other police agencies really wanting Officer Reyes to come speak before them, it highlights to me again how valuable her training is. So I'll pass it over to Dr. Kroll. I think you may have something.
So, I think the response protocols are something that we will talk about, I think, is when we're ready, when you all signal we're ready to move to talk about where we are in terms of the mobile crisis outreach team and the work we're doing to reframe something. I would say that we are the crisis center in terms of all the calls that it gets a year, and I'll come back to the 211 comment at the end of this, but there are teams of folks who've been doing this work on crisis for a long time and have a really good, finely honed and well-trained sense of what the response protocols need to look like. That we have responded with police exclusively is an artifact of history and time, I think, and we are changing that and have begun to change that already. But you'll see that change much more clearly and more pronounced under the Crisis Now model. At the heart of this, everybody we've talked to around the country talks about the need for the folks who are answering calls, who are the call takers, the 911 folks, 311 folks, crisis center, to really understand and be able to triage those calls in a way that is guided by training and experience. And so we've worked with, and we'll be working with the Cahoots team that everybody has been talking about for the last year, and having them to guide us and to help do some training and look at our models for how we decide what levels of response are appropriate for any given call. So there is what has been and what will be. This is always, I think, going to be a part of an art. It is not a science. It is, you tell me that someone is acting strangely. There are a couple of questions about safety issues, a couple of questions about what the behavior looks like that may determine whether or not it's a behavioral health response, and even what kind of team response we make, whether it is someone who gently walks up to someone and keeps a 12-foot distance from them, or whether it is someone who can come and sit next to you on a curb and talk to you. All of that is part of the nuance that is that we will work to train our 911 callers, as well as our outreach teams and our mobile crisis teams over the coming year. So, and then just to circle back to one thing before I forget, in terms of 211, this is just another follow-up on 211. The comparison that OLO made was 211 to 311 in terms of calls, but I wanted to point out that we have other resources around this that are also in the OLO report. The crisis center gets 35,000 calls a year. People calling into the crisis center far more frequently than they do 311. The Everymind, not counting its text and chat lines, is an additional, I think, 15,000 calls a year. So there are a lot of avenues for folks that don't take them to 311 and don't take them hopefully to 911. But there are options that people are using that are that may account clearly for the low number of 311 calls that we get.
Great, thank you. Councilmember Glass, and then Council President Hooker.
Thank you very much, Mr. Chair, Vice President. Really good conversation. It's one of those that are, it's chock full of information, but also instructive as to what we need to do. So I appreciate OLO for laying it all out there and diving into the processes and also the procedures. And I appreciate case studies and looking at best practices from around the region and around the country as well. And so the report itself was full of that. And the takeaway for me, as has clearly been discussed, is the fact that 1/3 of all police responses are for mental health situations. And so that's what we're trying to figure out how to mitigate that. And Dr. Kroll, I've been attuned to the conversation and look forward to the next part of this conversation on the mobile crisis and the intersection of that work as well. But I think the broad takeaway with the dynamics between the calls, and I too share the curiosity as to why more calls are being placed to 211 versus 311. I'm not sure how we figure that out, whether some providers might be in their material sharing the 211 phone number as opposed to the 311, but it certainly is curious and speaks to, I think, the more general fact that, like so many other aspects of life, things evolve and people request new services or hope that public services and government services evolve and adapt to whatever the needs in the community are. And I think that's clearly what we're seeing with the police calls and clearly the calls to 311 and 211. And the only question I'm not sure if it's been asked or not. And so it's to Chief Jones. Again, it might have been asked, but I might have missed it. Is there a way for MCPD to track the data points that have been asked in the OLO report to keep some of these metrics?
So I think there are ways that we can do this. I think there are going to have to be multiple ways, though, right? And so I think there are ways we're going to have to do some reclassification of our clearance codes. That when we write a final report, when those reportable offenses our events occur, that we can be able to categorize an event such as a mental health situation. We can document that. But then there's also those incidents that I think right from the very beginning, when the call taker is taking a call, how can we figure out a way, if we can make that determination, right? And it becomes clear that there's mental health, i.e., as I noted before, when someone has told us, and look, this is my child, or, it could be an adult, it could be a teenager, but this person is, suffered from some mental health crisis, and we know that going into it. But that's what, to be added into the computer aided dispatch, that's going to cause some refiguring in our system. And so that's going to probably cost some money for us to be able to kind of reshape that. But, just as we've noted in the data collection bill that's out there, and we talked about, we're getting ready to go to the new RMS. I think this is an opportunity for us to build out those things in order to be able to collect those data points that we're speaking of, that gives us a better overall view of what mental health responses are being done by the police department, as an example.
Well, I appreciate that. And it would seem to me also that while the IT system needs to be reconfigured on the front end when the calls come in, most certainly there needs to be some capacity to change it once the report comes back and on the ground information is delivered, right? Because it might not have been called in as mental health support, but clearly the officer might report it back that way.
Yes, absolutely. There is an opportunity that you can always put information back in a call. In fact, the clearance, even though it might have started as one thing, it can be cleared a different way to give you that clearer understanding of what this call was actually all about. Correct. Yes.
Makes sense. Okay. Well, again, thank you for this conversation. The OLO report, very helpful moving forward.
Thank you. Council President Hooker.
Thank you, Mr. Chairman. Well, thanks first to Natalia for this great report, as usual. Dr. Kroll, man, I got a lot of questions coming out of this. We get 35,000 calls a year to the crisis center. That's almost 100 a day, 95 a day, I think, right? How do we know how many individuals that represents? Because to Chairman Katz's point, this is a lot of repeat callers, presumably, about repeat individuals.
It's a good question. I don't know the answer to that offhand. We can certainly take a look at that. We may not be able to track that with our current database systems. Right. But we can take a look and see what the data tells us at this point. So there would undoubtedly be, of course, as Fire and Rescue does, as Every Mind does, we have some repeaters, folks who call in for a variety of different reasons, but they call in over and over again. So it could be repeat.
But if I'm calling about my bipolar mom is in this crisis again, you get the name of the individual, right, who I'm calling about, and you think you're not able to sort to pull out the number of individuals this might be?
It depends on how long the call lasts, what information we collect, what information they're asking for. Sometimes it is an informational call.
Yeah.
Advice, and we're not into the details of the client. But
what services are available, right? Okay.
Maybe son is having an odd reaction, but don't need hospitalization. Which can I take them for hospitalization? Where can I get some help for them? Where do I get emergency medication?
Right.
Something else.
So then I think you just answered my next question, which is there whether there's a different protocol for folks for whom I'm calling for the third time or the fourth time or the fifth time, if they're routed differently than people for whom it's their first call?
The crisis center treats people as each call as an individual item. They may have a record. If someone has called in several times in our system, we may pull them up in the database and look at what's been done, who took the call the last time, to the extent we have that information available, and see what the recommendations were. And so they can proceed there based on whatever history, or based on whatever history they might have.
Everybody does have a record that the call taker could look at.
Potentially.
Definitely our legislative aides know who calls very frequently about a pothole and who doesn't, who's calling for the first time.
Sometimes our folks have, they've been there long enough to have known, here comes Mr. Hooker again. Dorna, you have a good relationship with him. Why don't you take this call for us and talk to him and see what's going on with him?
That's how you are when you come to the Public Safety Committee about my questions, right?
And Dr. Kroll, I say the same thing when we used to be in the office. And here comes Hooker again.
I know.
So that protocol may vary, and it may be that if there's someone who we worked with actively and spent time with in the crisis center, been out on a crisis call in response, and have them in our health records, then, or if they've had sometimes a police history, we may be able to pull up and see what their record was, what services they received in our system is, if they were in Jazz or in CATS at some point during a stay in the correctional facility. It gives us some information that helps us to figure out where to go next.
I'd still love to see these scripts at some point, because so if I'm a call taker and I'm taking a call from Chairman Katz and he's calling about his neighbor, I wouldn't necessarily have, even if he's called 10 other times, I wouldn't have information necessarily about that previous calls or the medication that individual's on or how those calls have been disposed of. Is that right?
Depending on the history of what we know with the person, but and depending on how long ago the call was, we get calls that may be 6 months apart, a year apart. They may have called longer or in less time. So that for us, it is an assessment of immediate safety of the people that are calling, the current behavior, the mental status of the person, and then a decision about whether or not we need to send someone out. We need to advise them to call 911 or to call. Or to bring them into the crisis center for an evaluation. So it is a case-by-case basis. Some mental status exam, if it is a person, to try to get a sense of whether or not they are hallucinating or experiencing some form of psychosis. Just on over the phone kind of mental status.
There's not a searchable thing where I could type somebody's name in, like when I'm calling for my hotel reservation. They say, oh, here's Hooker, here's his record, here's the number of pillows that his wife likes, or the number of, whether he likes to be on an upstairs floor or downstairs floor. You don't have that kind of.
Not universally, no.
Right. Okay. The chairman mentioned how much this shows the widespread demand for these services and the direction we're headed. But I assume, if anything, this is underreported and underassessed. Is that your assumption, Dr. Kroll?
In terms of the number of calls that law enforcement gets that have mental health issues, or
just gives us a window into the demand that's out there, but we know a lot of demand never actually picks up the phone and calls us, is my assumption.
Yeah, I think there are a lot of people who don't call us. I mean, I think all the time there are a lot of folks who either manage it themselves. They find another route. They go straight to the emergency departments, and we don't see them.
Right.
They are arrested in some cases for a legitimate offense, and it's just not clear that there's a mental health issue necessarily right away. And then once they're in Department of Corrections, things start to emerge. So one of the reasons we put CATS in place is because we find people periodically who have mental health issues that emerge after they've been in the facility for a period of time.
Right. Yeah. I mean, there's no question. I'm sure more people call 911, but I'm speaking to. I know there's Black and brown residents who are scared to call 911 because they think there might be a disproportionate response, right? Right. We only call when things are really, really bad, if at all. We know there's low-income people that are less likely to call the government generally. We know there's immigrants that are less likely to call the government generally because of the government of the nation that they left. We know there's undocumented immigrants that are definitely not likely to call, right? And I assume, even though we probably have lots of immigrant families that would call to pick up a bulk trash pickup, but wouldn't want to call about mental health because of the widespread nature of stigma, right? So I look at these numbers and I just assume the market that's really out there is much greater than what we're seeing.
Well, the prevalence of mental health and mental illness in the county, the national prevalence around depression or mental health issues is around 20% for the population, but only a small percentage get to the point of severity where they need some more intensive action. We haven't done this recently, but maybe about 5 years ago when I was chief, we took a look at the federal and the state projections of the prevalence of mental illness and substance abuse in the county, just in relationship to the number of therapists and the number of people we were seeing. And it was clear that we were meeting about 50% of the projected need in the county in terms of ongoing therapeutic services, not counting crisis center, but ongoing therapeutic services. So the need is definitely out there. Sometimes people have a need that is transient need. You come in a crisis and you get it resolved. Sometimes that is one of the reasons we teach mental health first aid in the community as broadly as we do, is because sometimes a mental health problem flashes up and is resolved before it gets too serious. We have a lot of people in the county that are eligible and accessing private mental health services. I mean, the private sector for mental health meets a lot of the need in this county because there are therapists. I mean, you could throw a rock down 355 and you could probably hit 2 or 3 therapists without trying hard. But I think so some of that need gets met in other ways. I think OL did a report on this a few years ago that talks about mental health services and capacity in the county, around looking at the number of therapists and providers in the county.
I assume the state doesn't have a mental health reserve corps the way it has a medical reserve corps.
Oddly enough, we used to. A few years ago, we had up until 6 years ago, we had a relationship that was brokered through a contract with Evermind, actually, to stand up an emergency corps for mental health professionals so that in time of crisis or emergency, we could activate them. They were private practitioners that we were providing continuing education to in exchange for their being available to call upon an emergency. We maintained that for the first maybe 4 or 5 years of my tenure as chief of behavioral health, and then budget cuts forced us to do some reductions, and so we eliminated the program. There's a medical reserve corps that could, and if we ask them to, identify therapists or people who have mental health backgrounds and call them up. But, it's not really active in the moment.
Okay, that's really helpful. And Chief, I'm really glad to see the numbers on the breadth of mental health training for your officers. As important as that is, I know all of us agree that we can't expect your officers to act as social workers. Social workers go to school for many years and then have lots of continuing education and lots of training in the field. I just want to say again, I'm really grateful for your support and Dr. Kroll's support for the direction we're headed. And as you mentioned the mental health court, just because it's been so long since we had a reminder, that's the mental health court we have is just for adults. And I think we still need one for juveniles. And at one point pre-pandemic, this joint committee expressed an interest in touring the one in DC. And I would think we still want to do that at some point. A couple questions. Will any of the data areas identified by OLO in the report as lacking, can somebody remind me whether they'll be collected as a result of the community policing law, Bill 4520?
I believe so. Yes, I believe some of that data that would be part of the plan to work with our new RMS system, our records management system, in order to be able to help establish some of those. And I believe some of the asks in the community policing bill are related to that data collection.
Thanks. And the average of 154 minutes it takes an officer to respond to a behavioral health response call. Does that include the travel time to the hospital? Does it include the time waiting in the hospital before there's a transfer of the custody?
Yeah, it includes all of that. That quote there should actually say officer with S on the end of it in parentheses, because sometimes it might be multiple officers that are involved. Right. But it does include, yes, it would include the time of arrival during the entire time until that call is cleared by the officer at the very end.
Okay, so it does not even the travel time on the front end.
No, right. So until when that call is actually received and dispatched,
not coded that way,
the clock starts ticking. Yeah.
Oh, you're saying it does include the travel?
Yeah, it does. The minute the call is dispatched, the clock starts ticking.
Okay, so then time in the hospital and the time writing the report afterwards?
No. So once the call is cleared, the officer can write the report after they clear the call. But once the officer clears the hospital and clears the call, then that's the end of that particular call, right?
How long does it typically take an officer to secure an emergency petition?
Well, it doesn't take really long. It's generally it's a one-page document, and it just has to be, there's information that's required in that particular petition, it basically, there has to be a narrative, again, of facts of exactly what caused the officer to actually bring this person in to be petitioned, and it has to be signed, and that documentation has to go to the doctor. Because that is kept in a state records of from a mental standpoint, and I don't know where it goes from there, but I know it stays with the hospital from that standpoint. But whether or not we fill it out, or a family member can do the same thing, right? They can go to a district court commissioner and actually file that, and that's where the sheriff's department may come in from a court order petition, and they would then go and actually serve that court order.
Do we know thank you. Do you know what the status of that bill is in Annapolis to make it a little more streamlined to secure an emergency position?
I am not, I hear it may be moving forward, but I'm not 100% sure where that is right now.
I texted Mel too, but I don't.
Yeah, we may know, yes.
Natalia, can you remind me where Maryland 211 callers, when they call from Montgomery County, they're routed to the call center in Prince George's, and where does Prince George's tell them to go after that?
So the 211 system, they compile information about different resources, including resources in Montgomery County. So that person wouldn't be routed to Prince George's County just because they reached the call center there. They would be routed to resources that are close to them.
And that call center has obviously the information on it, just any resource in Montgomery County, they're routed from that call center. Okay, at the state level.
Correct.
Okay, thanks.
Yeah.
And finally, Mr. Chairman, thank you for your patience. We have a new federal administration. What does that really mean for opportunities for federal funding in this area? Uh-oh. Some other jurisdiction might be getting our grant.
It was like the sound of silence.
I'm sorry, was that a question for?
I don't know. I didn't address it. Sorry. Yeah. Do we? I know nobody from OIR is here. They're all busy in Annapolis. But do we know whether there's more funding coming from SAMHSA or anybody else about helping local jurisdictions stand up mobile crisis centers, or expand their call centers, or crisis call centers, or stand up mental health courts and expand them, or anything else?
Well, one of the things that Dr. Santiago is here and can talk about as we talk about mobile crisis outreach team is the SAMHSA grant that we have submitted for this year that is designed to help crisis centers expand their operations and strengthen their operations. So, yes, there are grant opportunities that are surfacing, and I expect will continue to surface as we try to pull out of this pandemic.
I realize it's early, and we're trying to track those down. Dr. Santiago?
Yes, I'm sorry. Just about an hour before this call, I sent some information to NAMI because I think the state is considering a bill for crisis response. I think it's a program that has existed already because I did see a number of different jurisdictions that have received funds, but they must be considering either expansion or maintenance. I'm not quite sure, but I provided the information they needed. So I think there's a state bill about it.
Right. So if you're able to check with OIR, and I can too, just about what the federal waterfront looks like on this topic. I just don't want us to miss out on potential funding that's out there. And I imagine, I haven't really paid attention to what the president and vice president have said in this area, but I imagine there's got to be more funding available at the federal level.
Yeah. Concerning the grant that we just submitted, I understand that the stimulus package may have even more. It's for something called Certified Community Behavioral Health Clinics, but it does have funding for crisis response, and that's how we're going to use it,
okay,
if we get it.
Right. Okay. Terrific. Thank you, Mr. Chairman.
Thank you. We've been joined by Councilmember Will Jawando, and he has a couple questions. I have some questions that I'll save for the end because I think they'll help transition us to the second item on the agenda. But Councilmember Jawando.
Thank you, Mr. Chairman, Mr. Vice President, Chairman. I don't know if they have to say both titles, but I'm happy to do it. Ms. Carasosa, thank you as always for a very high quality report. I had the benefit of being briefed, as my colleagues did as well, by the administration staff on the Crisis Now model that they're working on. And I'm glad Dr. Santiago is here as well and his team. And Dr. Kroll, good to see you as always. I'm really happy, as I think all of us are, that we're moving in a direction where we're relieving some of the burden from law enforcement and trying to reinvest and refocus in our social service and mental health and our other social service infrastructure so that we can have better outcomes. And this is a great part of that conversation. Just a couple of things that stuck out to me in your report, Ms. Carasosa, that I wanted to, and anyone, there might be relevant people on here to respond as well. Talking about the data, like our homeless shelters, you mentioned here that there is an overrepresentation of Black residents that are involved in an underrepresentation of Latino and Asian, which is equal. Both are a problem, related. Could you talk to me about when you say, and it's a two-part question. When you say that, what are you basing those numbers off of? And forgive me if you've already went all over this. And then onto the point of these calls that are tagged as mental health calls, and this might be a question for the chief, where are we getting that determination? Is this something that just results in hospitalization, or, because I see Assistant Chief Patil here, we've had discussions about the call center and how the calls are coming in and how they're assessed and how they're tagged. So could you just answer those two questions? What are you basing that demographic data on? I know it's limited, but what are you basing that on? And then the secondary question is, how are we categorizing a call that's mental health related and using those time, the amount of time, and producing those statistics?
Sure, certainly. So the first question regarding the demographic data, the mobile crisis outreach team data comes from DHHS staff. They can perhaps elaborate on how they collect that information, and the data on the petitions for emergency evaluations is from the records management system, the police records management system, e-justice. So that's where it comes from, and I just literally was comparing it to the population data from the Census Bureau. So I did do some digging into sort of like the incidence of mental illness, and particularly as it would relate to use of psychiatric emergency services, but that's quite a complicated topic that I was not able to delve into deeply for this particular report. And then in terms of what is included in the 19 calls, 19 responses per day, what I did is I looked at the calls as the disposition codes that were assigned by the police officers that responded. And that disposition code simply refers to mental illness. I also included the ones that referred to suicide or attempted suicide. And they are not broken down by the sort of like outcome of the call currently. So we don't know from those data whether a person was hospitalized, or whether it was resolved on the scene, or whether that person was referred to other services. That information is not currently available, although our recommendation is for that information to be collected. But I was able to link the incidents that did result in a petition for emergency evaluation to data from the records management system in order to identify the ones that were resulted in an involuntary hospitalization.
Got it. Okay, yeah, because one of the issues that I think, so that there's obviously calls that deal with individuals that are having a mental health crisis and or issue that aren't captured in this kind of petition process? So that I think it'd be a fair statement to say that there's a much larger universe that is not being captured. Would that be correct? Yeah.
Yes.
Yeah,
Yes.
that's correct. I mean, again, as I noted before, Councilmember Jawando, you could have a call for service, and we never, in no emergency petition, there's no report written, right? And we could have gotten a call for someone, being disorderly on a street corner, for example, and we respond, and the individual isn't of harm to himself or to others. He's just going maybe through a little bit of paranoia or whatever the case may be. The officer may talk to that individual, make a determination. Yeah, they may be going through something. Maybe there's some outreach, and we notify someone, and maybe we don't. I don't know. I'm just saying that it may be just clear, because it will say that the individual's not of harm to himself or others. He's not doing there's no crime being committed, and we simply clear the call, and it may
So
be
that's
clear.
that wouldn't be tracked necessarily.
No,
There's a lot of those that happen.
that's exactly right. Yeah,
Right.
I mean, simply, again, and how do officers make these judgment calls, you might say, or you say, how do we know, and for the calls that we actually, I'm clearing our mental health? Well, a lot of that is based on their training.
Sure.
Some of it is for past information that we've dealt with some of our clients, as repeat individuals that we know about. We've dealt with them on these types of incidents before. So that could be brought into, and the officer could clear it as a mental health call, but no report written. But they could get cleared as something else,
Right.
depending upon how that call came in.
I appreciate that. I think it just underscores the point of why we're here and why we're doing this, because there's so many gaps in this, and that just what we know, and how everyone's being put in a difficult position, from the resident all to the law enforcement to everything in between. And that's why I'm glad we're really addressing it. So I look forward to continuing to work on this in a whole number of ways, in partnership with everybody. And I'm glad we're heading in the right direction. So thank you for the report. And thank you for letting me join the joint committee.
Thank you, Councilmember Jawando. I had similar questions, so I'm glad you asked them. These are more points than questions, but I think there's going to have to be a part 2 of this discussion, because in addition to the complexities and multi-layers involved on the front end of the calls in the immediate response, I'm just as interested in the back end and what transpires once a call comes in, a referral has been made. Where does that go? Where does that live? How is it then communicated back to law enforcement? And because this is only part of the story. And so I'm going to humbly request at some point in the near future that OLO follow up on that aspect of it, because as was pointed out in the packet, we're often only as good as where we can refer these folks to. And as we know, it's a very complex system. There aren't enough beds. There's not enough infrastructure and capacity. The laws surrounding how these individual cases are addressed from both the court system, but also within the behavioral health system, is complex. It's multi-layered, and it's not a one-size-fits-all. So I think that it will, and it adds to the cycle and the challenges that we have before us. If somebody who, in the vast majority of these cases are handled well and don't result in tragedy, clearly. But I think there's a lot more that we can do to provide treatment and support for the residents that call in the first place. And then the other point that I think we're going to need to follow up on, Council President Hucker and I believe Chairman Katz asked about this, but those initial assessments in 911, those calls to 211 is a critical component to all of this, so that they can then provide the necessary information to the officers that are on the ground or the first responders. And I appreciate it, Chief Jones, you included the behavioral health specialists in the first response team, because they are first responders. And I think that's relevant to this discussion, thinking about this in those terms. but that's also important. And so I will pose some of these questions as a follow-up to you, Ms. Carrizosa, and ask Chris if it's okay for you guys to continue this work in the next phase through another project. I'm going to request that you continue this work since you did such a great job on this aspect of things. And I also think that this can help inform going into next year some advocacy in Annapolis, because a lot of the laws and regulations are out of our control with regards to a lot of these issues. So that's another layer of complexity. So great job, everyone. Thank you. Appreciate the hard work that went into this. We're 2 hours in. We're going to now go into the next discussion, which is item number 2 on our agenda. And with that, I'm going to ask that Ms. McMillan just provide us with a general update here and then walk us through the packet.
Yes, and so this is an opportunity for you to get a little bit of a targeted update around the mobile crisis outreach teams. And has already been mentioned that the council did approve funding last summer to get a head start on adding clinical positions. I did note for you, since the budget came out on Monday, that the executive's budget not only continues that funding, but has additional funding in so that there would be the ability to create a total of 6 teams. The 3 teams that were the minimum that could be created with the first 6 positions, and then the new positions, which will allow for a total, as I understand it, of 6 teams. So they can give you an update on where we are with the hiring of the positions that were already approved, and maybe give you some insights on the other positions and what's being planned to get to the other teams. But also, the other issues are where we are in the development of the protocols. There were really 2 key issues, in addition to expanding the number of teams, that the council was most concerned about last summer. One was the protocol, so that we could have both response with police, but also response by mobile crisis team alone when that was appropriate, and that does require a change in protocols. And the second other issue was to make sure that the teams are being deployed from different parts of the county and not just Rockville, in order to address the time issues, which of course the OLO report also notes some of the time it can take right now for the crisis team to come when they are requested by police. And I also then wanted to have you have an update on the status of the crisis beds at the crisis center. COVID did impact the ability of the department to keep those crisis beds open. And so I wanted the committee to have an update on where we are with that now. And I just would also emphasize that while the OLO report was really discussing mental health, people having a mental health crisis and mental health issue, we do know that the crisis center does respond to a range of issues when people are in crisis. It might be attached to a call related to a domestic violence or child welfare. It could just be to de-escalate a situation in some kind of congregate setting. So there are a variety of calls that the crisis center is responsible for, in addition to those really important responses to people who are in a mental health crisis. And I think with that, I would just turn it over to Dr. Kroll and to Dr. Santiago and to Ms. Hill, and they can give you the updates.
So thank you, Linda. Thanks for giving us a chance to come back and give you an update on this. I'm going to do a little bit of the background and history around this and bring you up to speed, and then turn you over to Dr. Santiago, who will tell you where we are at this point. Councilmember Hucker, you through, I think, a supplemental that went into effect at the start of the fiscal year, gave us support for 6 social workers to begin the process of expanding mobile crisis. And we started a process of recruiting those therapists that is underway, and trying to get them on board. And you were appropriately kind in your opening remarks about the length of time, knowing the length of time it was going to take us to stand those up. And so you acknowledged that recruitment is a slow process. I want to say that the recruitment was slower than anybody imagined. we ended up with COVID being a little bit more of a lingering cold than we had planned in the county. And I will also say that my recruitment for Dr. Santiago was slowed and took a little while longer than I expected. So getting somebody in the chief's position took a while. And in the middle of that, our senior manager for crisis and trauma services decided to retire. So we got all of our management and process significantly delayed. And we found, as Dr. Santiago came on board and started recruiting, that people weren't moving a whole lot in terms of changing jobs. And so recruitment took a little longer than it has. Dr. Santiago will give you the good news in terms of where we are in terms of recruitment, where we are. So I will not steal that thunder from him, but I wanted to let you know in advance that this has taken longer than I expected, and then longer than typical. And it is not purely an HR issue in our historic process. There are just a whole series of factors that converge to slow us down some. The good news, the additional good news, is that the county executive did add in the budget 6 additional positions so that we can double the number of teams. So we go ahead and double the number of crisis teams. In our conversations, he's clear that this may not be a sufficient number of mobile crisis teams, but we are looking at what else we might be able to do to strengthen it beyond those 6. The SAMHSA grant that Rolando will talk about is set up to bring in an additional 6 positions so that we can expand and deepen the process, deepen the team even further, especially given some of the conversations we will have regarding school behavioral health and school mental health resources, and how that the mobile crisis and outreach team might fit in. The last thing I'll say before I stop is that I said this earlier. We talked about mobile crisis outreach teams as if that is one word and that's one team, when in fact there are a lot of pieces of health and human services where outreach takes place in response to the kinds of things that we typically think of as behavioral health issues. Folks who are on the streets and who are homeless, we have teams that are part of SEF, Services to End and Prevent Homelessness, as well as mobile crisis, and a series of other outreach services that take place in collaboration with in response to children. A mobile crisis stabilization team that is part of our process as well. The task for us is to really do a good job of integrating across all of those systems and figuring out how we put those together so that there is a good flow between all of those systems, between police, between crisis center, between all the various other services that we do that we call outreach services in HHS and across the county, including fire and rescue and things like our STEER teams as well. So with that, I'll stop and turn it over to you, Dr. Santiago. You can...
Thank you. Some of the information that Dornay and I will talk about, we've presented to each of you over the last few days in the calls that we've had with Caroline. So forgive us if you're listening to the same information, but there will be some new information as well that we'll provide. I'm teaming up with Dornay Hill. She's the administrator, the acting administrator for crisis and trauma services. And I'll take 2 of the questions that Linda referred to, and Dornay will take 2 of them. I think I'll go ahead and start with a question about the hiring, the status of the hiring of the 6 positions that you funded last summer. And I think it was, I wasn't here, but I'm quite sure that the history of that was generated by the incident, the George Floyd incident, and it created a sense of urgency to get our teams together. So we're very deeply appreciative. We just hired one therapist on March 1st. A second person started on March 15, just 2 days ago. And a third therapist will begin on April the 12th. With those three, we will be able to deploy a new outreach team, a second one, and it'll be 16/5, the day and the evening shift, and we're looking at deploying that team in the Silver Spring area, likely in the building across Progress Place, the building where Fire and Rescue and the Police Department have a station, and there's a number of other services, county services located there. So we're exploring, we're excited about the possibility of moving, having a team centered there. And then at the same time, we continue to hire for the additional 3 therapists. There are interviews being conducted. Fortunately, we've observed that over the last couple of weeks, therapists seem to be coming out of the woodwork. We're theorizing that perhaps it's the vaccination situation that is improving, and also the fact that the schools are opening and students and children are going to school, so that allows parents to think about employment again. We don't know the reason, but we've been getting more applications in several of the categories that we use for recruiting the therapists. So we're grateful for that. So interviews are happening. It looks promising that before the end of the fiscal year, we will have hired the additional 3 of the 6 therapists. And with that, when we do that, we're looking at the Germantown area as the second location for deploying a second team. And as you well know, that lends the opportunity for us to be closer to the action where a crisis does occur. The response times are lessened when we do that. So we're grateful for that, that's happening. Now, if we do get the same funding, and we will get also the fiscal year 22 appropriations and budget for of course, if the council so agrees with the county executive, we will have 6 additional peer support specialists. And with those, as Dr. Kroll was mentioning, we will be able to double, so go from 3 teams to 6 additional ones. And if we get the SAMHSA grant, we might even be able to push it up to 7 and 8, perhaps. And so we're very excited about the possibilities for us in the next year or so. So I think I answered both the question related to the status of the clinical positions, as well as where the status of deploying the new teams and the locations. And I'd like to ask Dornay to speak to the triage protocol, the status, where we're at with respect to having our therapists and MCOTs deployed without police presence, and then also the other question related to the crisis beds at the crisis center.
Ms. Hill?
Yep, I'm
okay,
coming.
Great.
Of course, I froze. I've been on here for hours and it froze and it's my turn. Good afternoon, everybody. Thank you so much for having us. So looking at the creation of a protocol where the mobile crisis teams can respond without police, we did a lot of research with other models throughout the country, looking at the triage that Cahoots uses, that RI International who did the consultation for the Crisis Now proposal. And they look at a 3-level triage protocol. The first would be where there is mobile crisis responding first and there's no police presence. They may know where we are for safety purposes, but they're not around the corner, they're not on the scene, they're not responding. Those are if they're schools, public buildings where there's other people around and there's a little bit less, there is less danger. The middle category would be if the person has a history of violence, is known to have been assaultive, or is usually aggressive in nature. We may have a police presence either around the corner or on the scene, but we would be the lead for that. The higher level would be if the police presence is a co-responder model, and that's if there is known to be weapons in the home, if the person has been actually assaultive towards police or towards other providers, if they're actually in an assaultive moment, if they're like breaking things and different things like that, it would be a co-responder response. So we do have this laid out in a document that I will share with you and get to Linda to get to all of you, that we've started working on that addresses these 3 models. So where we are in our process now is we are planning to meet with the police department, fire rescue, and others that this would impact to get their input, as well as we're going to look at some of our previous clients and speak to them and see what they feel about the model and the interactions and the different levels, so that we have a full community input to the model. And then we will work with our team to do the training through Cahoots for de-escalation. And I am in talks with Tim Black and the Whitebird Clinic now. And our hope is that by May or June, we will have the de-escalation training to roll out, not just to the mobile crisis outreach teams, but to our community homeless providers, the red shirts, the homeless outreach, the homeless providers in the actual shelters, and other community members that would have relationships and interactions with the same population as the mobile crisis outreach team. So as well as the residential crisis beds, I know it's been a long time coming, but Monday, March 22nd, we are opening 2 beds. Our facility does hold 4 beds, but based upon the co-location in the county building and the space that we have for eating and recreation, it only can have 2 people at a time. So that's our goal. And we do already have 1 person who's slated to come. We have revamped our intake process to be virtually based so that people can send us referrals via email and not just fax. And we are very excited to open those beds. And we are partnering with services to end and prevent homelessness to get some different food options and rapid testing and with public health. So we are using our partnership within HHS to make sure that everybody is safe and that it's a good place and a safe place for people to regroup their mental health. I think that was it for my 2 questions. Did I leave anything out, Dr. Santiago or Dr. Kroll, to your knowledge?
I think you did well, and Dr. Kroll, I think we're done in terms of our response to the questions that Linda provided. So we're ready for any questions.
But just one thing before we move on, I wasn't sure I heard Dornay correctly, but I wanted to emphasize that 2 crisis residential beds at Picard is a situation under the pandemic.
Correct.
4 beds just was too close in and too much risk for both staffing for residents at this point. So as we resolve that problem, we will ramp back up. And we did indeed shut down the crisis center beds for the early parts of the pandemic. These are not the only crisis residential beds that we have in the county. There are other providers that have them as well, and they're going through similar kinds of challenges with spacing and admitting folks to their beds. So it's a system-wide response to COVID at this point.
Correct.
Great. Thank you for that overview. I know our team enjoyed working with Councilmember Hucker's team on the development of this bill. Appreciate that collaboration and partnership, which was awesome. and the follow-up. And yes, I think all of us have acknowledged challenging this year has been administratively, so definitely understand the longer runway needed to onboard these positions. And good news that you're getting some more applications and more potential candidates to choose from. It is a fascinating hypothesis you made with regards to folks coming back into the workforce, but I think you're absolutely right. That and then hopefully that will help us in other categories as well. So I want to start with just a few comments. The first is the council president and his team and I have been meeting regularly with stakeholders in downtown Silver Spring. We let them know about this exciting initiative almost a year ago. They've been trying to wait as patiently as possible with a lot of challenges in downtown Silver Spring, as the team knows. I would strongly suggest that you schedule some time to meet with them, particularly the Chamber of Commerce, with the new representatives once they are onboarded, so that relationships can begin to be established, questions can be answered in terms of scope and what this program is and what it is not, what the limitations are with some of those policies I mentioned earlier that cross over to the state level, and the fact that we are in a state of transition before we figure out exactly what this will look like in each respective community, because the needs in Silver Spring are different than the needs in Germantown. The needs in Germantown are different than the needs in the eastern part of the county. So I think acknowledging some of that and getting some of that buy-in initially will be very helpful. And I can see, Dr. Kroll, you have some thoughts or comments on this.
Just to say that we have been meeting with the Silver Spring groups continuously with Ms. Harris and then with Dr. Santiago since he's been on board, to try to keep them up to speed and up to date on that. But also built into the plan that the Crisis Now planning is to do some community forums and some community training with that community, so that there's some sense of expectation. And one of the things we're trying to do, and I don't know where we are on it, is to actually have Cahoots do some of that community forum, so that from the folks that everybody has been looking at as the model, what they do, what they can't do, what the limitations are around a community response that does not involve law enforcement. Because there are some limits and some realities that I think that folks need to be aware of. But it is very much, we made the decision, I think Rolando made the decision to go down the county with the first team, precisely because of the intensity of the needs in the Silver Spring area.
And if I could add a couple of things, just this past Monday, Dorne and I met with Remberto, and he listed for us a number of groups that we should reach out. I was just astounded at the number of stakeholders that we could be doing outreach. And the purpose was to see with which groups we want to do the Cahoots community trainings, because they will provide community trainings on de-escalation and community outreach. And the Chamber of Commerce, of course, was one of the groups that he listed. The other point I wanted to make is that, as you probably are aware, DC, trying to remember the name of it, but they just hired through CEF, they hired 2 street outreach workers.
Pathways for DC.
Pathways DC, yes. So they're already on the ground. And Dorne has told me that the plans are to have our team collaborate intimately. I think there's already conversations going on, collaborate intimately with the Pathways DC group. It's all about collaboration and talking with each other, communicating. And we'll be there with the police department as well, and also fire and rescue. I mean, it's all, we're in a good place, I think, in Silver Spring.
Good. And I'd like to suggest maybe cross-reference that list with Council President Hucker's office. I'm sure Rienberto was exhaustive in including that, but I think he'd appreciate that follow-up as well, anticipating a question he may have.
Yes.
Just a couple of other questions. What is the clinical background of these therapists? Are these clinical licensed social workers? Are they MSWs? What is their background?
So, sure. So they are a combination of independent licensed social workers, so LCSWCs, and independent licensed counselors, LCPCs, thus far.
Okay. And then I know it's always challenging with recruitment, but do any of these folks have a background in multicultural programming? Are they multicultural themselves? Is there the opportunity for, onboarding folks that potentially are even bilingual?
Yes, so we have several different recruitments. We have a specific recruitment just for Spanish-speaking therapists. We have not yet found a Spanish-speaking therapist. We are interviewing a few later this week. Currently, the combination is 1 African-American and 2 Caucasian. There is no language capability at this time with the new hires.
Okay. And who are they reporting to specifically? Like where do they fit in the HHS structure? Because obviously they're going to have to be in a position to make referrals to multiple different divisions. And so what does that look like internally within HHS? Just curious.
Sure. So we are a part of Behavioral Health and Crisis Services. So Dr. Santiago is the chief. I'm the acting senior administrator. I'm also the manager of the crisis center right now, and I have 4 supervisors under me who will do the actual onboarding training, and they will report directly to them. And we, of course, collaborate every day with services to prevent homelessness, child welfare, homeless outreach, homeless family outreach. We also are in the same building at Picard Drive with medical assistance, food stamps, all those different services, housing assistance. So we work with the school system, MCPS. We actually have 2 diversion workers currently housed from SEF at the crisis center. So we work diligently with all of our partners within HHS and in the community right now.
I appreciate that, and obviously these folks can't work 24/7, and obviously it's great news that we're adding 6 thanks to the county executive's recommended budget, and I think you guys are in pretty good shape with those 6. Reading the tea leaves and some of the conversations I've had with my colleagues, and great news that we've applied for SAMHSA, so we may be receiving some on top of that. But right now, given the overwhelming need, how are you strategizing the deployment of hours of operation? Will these be covering evening hours, daytime hours, mostly weekends? I mean, obviously this is
right. So
it's cyclical in terms of when the calls come in. You never know.
Right.
But just curious as to what, it's not a 9 to 5 schedule. So what does that look like?
Absolutely. So right now we are using all of the staff at the crisis center to fill the mobile crisis team. So the additional staff will go into the pool of already 24 therapists. And we are using 3 teams from 7 a.m. to midnight, Monday through Friday. So there'll be one 24-hour team, 7 days a week, 24/7 out of Rockville. There'll be one team in Silver Spring, Monday through Friday, 7 a.m. to midnight. So there'll be 2 different teams. So they'll work 2 8-hour shifts.
Gotcha.
And then the Germantown team will also work 2 8-hour shifts, 2 different teams. And the weekend will still have the one 24/7 team for right now. We are beginning conversations with labor relations and union and other people about the schedule and shift work and how we can realign that to work with our new model and the new staff. So that next time we meet, there may be changes to that. But right now, that's where we are in the process.
I've been there. That's going to be a very sensitive conversation.
Correct.
My last question, and then Councilmember Glass has his hands raised, and then any other colleagues that would like to chime in, please let me know. But we mentioned this in the previous discussion, but such a critical component to this entire system is that initial call and that initial call taker. Whether it's 211 or 911 or 311, there's a lot on them to evaluate and process and make the appropriate referral and provide the appropriate background. I know when we initially applied for the state grant, there was some discussion about having part of the behavioral health team actually at the 911 call center, so that there'd be a more robust response and somebody with the clinical background that may be able to help better assess calls as they're coming in so that the appropriate deployment is made. Obviously, we can't get there right now with the funding that we have, but are there plans to phase something like that in the future? And if so, what might that look like?
So I'll start that and we'll pick that one up a little bit for us. But the Crisis Now model calls for an integrated, what do they call it? Air traffic control kind of one large center. And we obviously with 311, 211, Every Mind, the Crisis Center, 911, where we have had things that have evolved over the years, just as a natural course of evolution in the county. The first task around this is to figure out how we integrate and get everybody on the same page and be able to communicate and coordinate. My conversations with Chief Jones early on in this process was that we should be looking at whether or not there's an opportunity to integrate behavioral health teams or persons in the 911 call center as part of that process. So getting everybody trained and getting everybody coordinated and then looking to see where we are, I think is part of the process when I last touched it. So Dr. Santiago, Chief Jones, maybe there's some updates from you all on that.
Yes, one of the things that I've done since I started is meet with Cassandra, and she's on this call as well. She's the director of the Emergency Communications Center, and she showed me the operation. Pretty impressive there at Quince Orchard. Our conversation was primarily talking about what Chief Jones had alluded to in the previous discussion of how we document, how the police department collects data. And she very wisely suggested that we start we work ourselves backwards. We start, with the incident report and then go backwards to the time that the call has been made, so we can understand fully what were the dynamics in identifying whether this was a mental health crisis or not. Of course, the on-the-ground presence is what's going to determine much better whether that was a mental health crisis. And I don't know if we would want to invite Cass to make any comments about that, if Chief Jones think that's wise or what have you, but it's a good question.
Well, why don't we include that as a follow-up to more deeply go into this? But I appreciate the initial response, and it sounds like there's agreement that this is important for sure. And as we are in a better position to move this forward, we should look at that. Councilmember Glass.
Thank you very much, Mr. Vice President, and I'll be very brief because I had a series of questions that I wanted to dive into a little bit more, but they were answered in the presentation and then answered with the chair's round of questions, very thorough. So hats off to you for asking all my questions. I will just add this then. A number of us, as the Vice President has noted, have been in these conversations, and unfortunately, because of our open meeting laws, the chair of the HHS committee and I have not been able to attend the meetings together. So we've been circling each other, but it underscored, and I believe President Hucker and his staff have been in all of those meetings, and it underscores the importance that we collectively view this issue with, right? And so I appreciate the attention to this subject, the sharing with us that finally we have moved the needle after lots of concerns and questions. And if there's anything that this last year in this pandemic has shown us, is that we can find ways to do things better. And so if there are ways to do this process better, let us know. Because it certainly took longer than any of us would have liked. And I know the same is true on your side of the street as well. So that's a different conversation for perhaps a different committee, but we can always do better to serve our community with the speed and timeliness that they need. and that we know it needs as well. So thank you for this work, and I'll continue working with my colleagues together informally or whatever open meeting laws allow us to do so that we can keep our communities safe and keep our most vulnerable housed and receiving all the support that they need. So thank you very much.
Thank you. Don't see any other questions or hands up. So I think with that, Ms. McGillen, anything else that you wanted to make sure we covered in this part of the agenda?
No, I think this has been a very thorough update on the issue. And I think we're just all really glad to see that the people have started coming on, the therapists have started coming on. It's really very exciting.
Terrific. Well, thank all of you for your continued leadership. We now move on to the third item on the agenda, which is to discuss a supplemental appropriation in the FY21 operating budget for $508,000 and $853 for medication-assisted treatment programs. And there will be a vote expected after this. So, Ms. McMillan, if you could walk us through this packet.
Yes, so we have representatives from the Department of Health and Human Services and Correction and Rehabilitation and the Sheriff's Office and OMB who can talk about this from a system perspective. This is a supplemental appropriation. I do just want to say from a process standpoint, it was fortuitous that this meeting was scheduled. So we're having the work session now before the public hearing. And of course, if something comes up at the public hearing, the Joint Committee can always choose to reconvene. But hopefully you'll be able to take your vote today and then we can move this forward quickly. And so this background, the background on this is it is for a medication-assisted treatment program for detainees, but it works through the system. I'll let the department representatives talk to you about it. I did include in the packet just a little bit of background information from NIDA, from the National Institute, because it's very important that folks really understand the prevalence of opioid addiction that is in the detainee and the inmate population, but also the importance of getting people treated, in part because as people don't have access to opioids, their body does change. And so there are very specific issues around making sure people get the treatment that they need, so that later on, when they're no longer detained, there are issues around what happens if people do start to use again. So we don't want them to use again. And medication-assisted treatment is an extremely effective treatment for opioid use disorder. But I think I would let the partners in this project give you the background on the program. This is a state grant-funded, federal funds via the state, and of course, council staff does recommend approval.
Great, thank you, Ms. McMillan. Director Talley, would you like to start? I think you're still on mute.
Okay, I'm sorry. There we are. Good afternoon, everyone. How are you? So House Bill 116 is passed and I believe became effective October 1st of 2019, and we had to stand up the medication-assisted treatment programs. We were one of the lucky 4 jurisdictions who always go first. And so us, as long as Howard County, Prince George's County, and I believe it was, Hardy, you can remind me of the 4th county. We had to stand up this program within 2 months, from October 29th, 2 to 3 months, and be ready to go January 2020. Like I said, it's a joint effort between Health and Human Services as the health authority for Montgomery County and Department of Corrections to identify individuals who are coming into the jail system who have been identified with an opioid substance abuse disorder. The bill covers 2 parts. The first part is, of course, any continuation, when you can verify that a person was in treatment prior to their arrest, and we would continue that medicated assisted treatment that they were on previous to their incarceration. And the second part is to identify those who will be appropriate, who've been identified and assessed as having a opioid substance abuse disorder, who would be open to receiving the treatment while they're in jail. And so we would work with Health and Human Services to be able to do this and to be able to make sure that medication is received during their stay and appropriate handoffs to community once they are released from the institution. Now, we have stood up part one, which is the continuation. We still have some work to go before we start initiating new individuals in this program. Some of that is because of the way the grant was dispersed to the jurisdictions. Quite frankly, we had to use existing staff in order to be able to get this up and moving in January, which meant our nurses are used, our current HHS therapists are being used, our nurse managers are doing the coordination as we try to fill these positions. And of course, our correctional officers who play a key part in the observation to be able to mitigate any diversion of these substances into the jails. And so we have not started the second part of this bill, but as we increase our staff members, which Health and Human Services is the main driver and, foreseeing that part of it, and Hardy Bennett can speak to that, we will start part two. COVID also played a part in that, as we know that our jail admissions are down. Our daily population is about 550. We usually have about 750 people in custody at any given time. But a lot of individuals are being released and being placed on pretrial supervision out in the community. And so this will change post-COVID. And we ran into, of course, growing pains, things you don't know, things you can't anticipate, such as, we receive people 24/7. And so Monday through Friday, if they come, it's great. But what happens on the weekend, which we found out very quickly, we have to have on-call services and physicians ready to be able to immediately dose individuals who we received into our facilities during that period. And so we went through some challenges, whether that was DEA licensed in order to have the medication on site in a correctional facility, the X license, which is allowing us to bridge when we did receive people on the weekends and physicians weren't available, to ensure that people's medication wasn't discontinued during those couple periods of time. And so we are, like I said, 4 of the 24 who have started. The next 6 jurisdictions start October 2021. And so we recently actually provided some insight for other jurisdictions onto some of our challenges in getting this stood up in our facilities. And so what our part is, like I said, is identification, and then the coordination after we verify that person is receiving the treatment, working with our HHS physicians and partners to be able to make sure that the physician prescribes the medication, and then our nurses on site would administer the medication. Our correctional officers would observe this, the medication being administered and taken by the inmate, and ensuring that the diversion possibilities of being able to carry that medication out of our medical system into the general population is thwarted. And so so far I think we served maybe 30 something people. I believe if we didn't have COVID, it would have been more. We are finding that we need definitely an officer there, because additional offer presence, because we are finding that this is 3 times a day, sometimes 2 times a day for individuals. And so those are some of the things we've run into. But I think that we have with HHS developed a system that works. We just need, of course, the staff members to be able to be in place in order to keep it moving. Hardy, anything you want to add from HHS perspective before I guess we open it up to any questions that they may have? You can't unmute, just like me. Okay.
Yes, good afternoon. What I would like to add real quickly in terms of the HHS recruitment, we're working with our vendor, who is Athena Consultants. And I will say this, we have made tremendous progress. We have 5 positions to fill. 3 of the 5 are now filled. That includes a nurse coordinator, 1 peer specialist, and 1 therapist. We still need to fill an additional peer specialist, and we need to fill 1 medical practitioner. Most likely that medical practitioner will be a nurse practitioner at this point. And the good news that I can report today is that the person I'm working with at Athena Consultants called today and actually sent a resume. So this is the first resume we've gotten to fill the nurse practitioner. So the good and encouraging news is we may be 80% of the way in filling the 5 positions very shortly. And just to verify, those 4 jurisdictions were St. Mary's, Prince George's,
St. Mary's,
Howard,
there we are.
Montgomery.
Yes. Thank you, Hardy. And just to make the council aware, another partner who is, I believe, are the sheriffs on the line? I believe they are. If they aren't here, they play a key role before COVID in transporting individuals. I'm sorry, there you are, Brian. In transporting individuals in the community, which comes with their own challenges. And I'll let Brian, if he wants to speak to that. What has been incredibly helpful during COVID is that we've been able to do some of this through telehealth. And so we will see how that fits into our future.
Yeah, thank you, Director Talley. I don't really have much to add to the conversation at this point. Sheriff Popkin would have preferred to have been able to make it today, but he had a standing obligation. And since I was a participant in the first part of this afternoon session, he asked me to stand in for him for gathering information purposes and to answer any questions if any arise.
Thank you, Brian.
Great. Well, thank you, Director Talley. Brian, you're much more handsome than Sheriff Tompkins, so we're happy you're here, buddy. You can tell him I said that.
Wow.
I will.
All right. So, well, thank you all very much. I had a couple of questions. And first of all, from 30,000 feet, it's nice having a funded mandate as opposed to an unfunded mandate, which is what we are more accustomed to around here in partnership with the state. So that is really good news. I guess is this it's an ongoing grant, I assume. That's how we're able to find personnel, or is this 1 year funding, or how does that look?
Well, Kay Beckley's on the line and she can speak to the funding. I'm not sure if anybody from HHS is on here. I can recognize the names. Or is anybody on here, Hardy, from HHS who are providing the funding information?
I can speak to it briefly. I know that Regina Morales, who of course is director of and the deputy director for behavioral health and crisis services, has been talking regularly with the State Behavioral Health Administration. And the only information we have at this time is that it looks very good that this is going to be continued 1 more year. But of course, we found out the second continuation, late. I mean, I think we had expired, maybe we had gotten beyond 9/30 before we got the second SOAR grant award letter. So it's not the most organized communication coming from the state on this. But I know that we're also paying attention to what's in the federal package that just was passed by the Biden administration. So.
Great. And by the way, it's good seeing my good friend Kay Beckley on the line.
I think she's trying to speak, but she's muted. You're muted, Kay. There you go.
Yes, hi. Kay Beckley. So I'm over management services. Just one thing about the funding is that we do have to increase the nursing services. We're only doing initiations right now, but we're hoping to do more. And right now we're using 0.5 FTE, which is what is budgeted. But we're going to need 1.0 if we're going to move forward with looking at everyone. We also need 1.0 for correctional officers. So the funding, although they're budgeted it now, we did request additional funds for the future. And so the goal is that the state would fund those additional funds. And if not, then we would have to ask for funding from the county perspective. So right now we are on track using the funding that we have because we're only doing the people who are already currently on some sort of drugs.
Gotcha.
But also with medication too, we're going to probably have to increase that because we're using all the funding we have now. But if we increase the medication, we're going to have to increase the expense of it as well.
Yes.
So it'll continue to go up.
Right. So the program clearly is very important on a number of different levels. I am interested in having an expanded conversation at some point, not necessarily right now, on back-end substance abuse services and support. After folks initially come in, this is a triage situation, an important one that sets everybody up for success and helps ensure safety and security of all involved, in addition to the health and human service aspects of this. So I get this program on the merits. It's important, but part of, I know, a complex system that we can't get into today, but I'd like to explore at some later time, because that is also important. I've heard many folks say that it shouldn't take having to go to a correction facility for somebody to get the real treatment that they needed all the way through. And it's a complex issue that Dr. Santiago is trying to meet head on, and one of the many issues he's going to have to tackle moving forward. But it directly relates to this discussion and directly connects to recidivism, which obviously is a return on investment issue. So I see no questions or comments from my colleagues. So with that, I want to turn it over to my co-chair, Councilmember Katz, to make some comments and possibly even a motion.
Well, my comments.
Actually, I had a question.
Sorry, Councilmember Rice. I missed you. My bad.
No. I'm sorry. I apologize. Just very quickly, Director Talley.
Yes.
I know that part of the concern has been around the treatment aspect, especially when it comes to substance abuse. I'm also concerned about the hardening of the facility itself when it comes to the susceptibility of some of the drugs and things like that. Is there some thought given also to, outside of the programmatic changes, what else we might need to do to the facility itself to also help to alleviate some of the challenges we're seeing regarding drug usage within the system?
Oh, wow. Well, we could talk a long time for that one, Councilmember Rice. I tell you, and I was actually talking to Secretary Green this morning. He called me on another matter, and we were just talking about that. Same challenges that he's seeing on the state system, is trying to eliminate, drugs being inside the facility. What are we missing? What else can we do? I was informed that he had this special equipment to discover Suboxone, and that is the one. I will tell you that when you think about marijuana, cocaine, things like that, people always say these are the typical drugs, but the Suboxone strips you can look at it and you don't even know what you're looking at. That's how disguisable it is. And so, I know that some correctional facilities are looking at their mail policies. We were sued about our book policies, and now we have to let every book in the world into the jail, which has become a challenge. We have some devices that we can use that are able to light up and show that drugs are actually on a piece of paper, and the individuals in custody see us checking that. But I will tell you, it's so hard to miss. That's why we have to have a correctional officer that cannot be diverted, and we have to do it in our medical unit, cannot be diverted by emergencies and somewhere one quick look around and the person already has it on their finger, out of their mouth, and trying to be able to sell and make money. He was telling me how startling that is going. People are trying to sell it inside the state institutions for $500 per little teeny square. And so, locally we're hearing anyway 100, and we're doing our best, but it takes so much, because this is new for us when we think about the typical drugs being into a facility, because you cannot see it. And so you have to continue. And I will tell you, COVID has, sometimes with COVID, people are less in, before vaccines and we were having to hold on this, were people a little bit, I did everything I needed to do. And so we have to step up our efforts. We had to bring in use our state resources to bring in our canines to try to find drugs in a facility. And we have to continue to do that. And we have some other things that the warden and I just discussed yesterday, because this is new for us. And I think it's new for our facilities. What I'm hearing across my conversations across the jurisdictions is that in K2 are the things that are really problematic right now. If we had to say the two types of drugs being getting into the facility. And so we are all just, trying to help each other find ways to do this. And so we have to shore up, you're not going to get a large amount from this, but there are other ways, of course, that we know that people can get drugs inside a facility that we didn't even think of. So, some people have stopped mail coming in, period. They're using outside sources to ship the mail to. You get the pages, you get it, but that costs a lot of money. You're talking about a significant amount of money to outsource those services. Would there be any challenges by any community advocates about the fact that we're delaying mail to people, packages to people? I'm sure that would come, but I will tell you that at some point we may have to visit that and see whether it is worth that investment. I know we had some discussions when Secretary Green was the director years ago, but I think it was cost prohibitive at that time, but we may have to go back to some of those type of measures.
Well, thank you, Director Talley, and I apologize to both chairs, but I think this is an important point that we may need to revisit. Mr. Chair, Mr. Vice President, I know that, with your bill dealing with ghost guns and just keeping up with the latest in terms of what new iterations of things are, understanding that these are things that can be now just assigned to, they could be affixed to just paper. Just as,
oh yes, it's a
just as Director Talley said.
And it's scary for our children and teenagers and schools, because if we're having hard, we're the experts of, well, I wouldn't say we can find everything, don't put that out on us, but then they'll be trying to hire us to go to the schools. But you can imagine the difficulty when people think about stickers and things of that nature. It's a very scary time when drones can be on anything.
And of course, we know that the usage of that doesn't help when it comes to the treatment. And so our treatment isn't effective if we have the continued influx of the substances that many people are abusing. Right. And so from that perspective, it all goes hand in hand. So I apologize. I know we're at the time, Mr. Chairs, but did just want to bring that up and think that we might want to come back to this at some point. So thank you. And thank you, Director
Thank
Talley.
you for your question.
Agreed, noted, and Ms. McMillan, if we could make a note of that, I think that's a very good point. Chairman Katz.
Thank you very much. And please do not apologize, Councilmember Rice. That was an extremely important part of this discussion. And to Director Talley and to your entire team, you do a fabulous job. You sincerely do. I see you on many occasions and have many discussions with you. But to the point that when you need resources, and I know I'm speaking for 6 people right now, and they'll tell me if they disagree with me, but if you need resources, please do not hesitate to let us know. There's certain things that we can't afford not to do. And we will stand with you, and we want people to be safe. We want the people who are incarcerated, as well as every one of your staff, to be safe. And if it needs additional resources, do not hesitate to please let us know. We will work to get us there. And that's not just on your topic, but that's on all of these topics today. This is to get people to a better place as quickly as we can. So with that, Mr. Vice President, you have so many titles today. With that, Mr. Vice President, I move that we approve this amount of money, the supplemental appropriation, and it is with the caveat that after the public hearing, if there's a need for us to have an additional conversation, we should. But I, at this point, cannot imagine that information would come out of the public hearing that would suggest that we not approve this money. Thank you.
All right, we have a first and a second. Everyone raise your hand if you agree with the motion. And that is unanimous. All right. Well, thank you very much, Director Talley. Thank you to our partners in HHS for this marathon, but very important session, extremely informative. And with that, I believe we are adjourned. Anything else, Ms. McMillan? Nope. Yes, we are adjourned. Thanks, everybody.
All right. Thank you.
Montgomery County Public School students will be returning to school today, March 1st, 2021. Please watch out for school buses during your commute into work this morning. 1/2 of normal service. MCDOT also has implemented a